Neonatal transitional physiology. This is the science behind cord clamping. So a little perspective. I like to begin this lecture with a little bit from Dr. Frank Lewin, who is a German OB, and I met him several years ago at a conference in Brazil, a humanized birth conference, and he was doing a presentation on breech delivery, and when he went up, he started his lecture with, in order to do breech, it's hands off. You can only be hands off if you know normal. If you know normal, you also know when it's not normal, and then you do the least amount necessary to get it back to normal, and then it's hands off. And then he proceeded to do his lecture, which was amazing. He had great videos and great pictures, and he's a great presenter. And about, I'm going to say 8 minutes into his lecture, he stopped again, and he went to the front of the stage, and he said, in order to do breech, it's hands off. You can only be hands off if you really understand normal rotation, normal, like you totally understand what normal is. It's hands off when it's normal. If you know normal, you also know when it's not normal, and then you do the least amount necessary to get it back to normal, and then it's hands off. And then he went back to his lecture, and he stopped about every 8-9 minutes, went to the front of the stage and said the exact same thing. So by the end of his 1-hour lecture, he had probably said that about 7 or 8 times. Now, I already have a pretty good understanding of normal, but I have to say by the end of that lecture, I really had a perspective and a deeper understanding of how critical understanding normal is. That normal is the foundation. That if you really understand normal, not just what you were taught, not just the way it is presented to you, but have a real understanding of normal, the embryological blueprint, how we come into being, what is embedded in birth if nobody was there, right? Because up until 150 years ago, no one was there. Most women gave birth alone. And yes, of course, there were some deaths, but for the most part, birth works. Otherwise, we would not have survived or evolved as a species. So when you think about, how much do you really need to be touching the perineum? How much do you really need to be touching the baby when it comes out? Do you need to be touching the baby when it comes out? No. You know when it's not normal, and then you can act, and that's what you're going to get from the rest of this lecture. But another place of normal is after the baby comes out. After the baby comes out and it goes onto the mother's chest, to not touch it, to let the baby do what it knows to do, which is every baby mammal knows how to find the breast, every single one. So certainly if you know normal, you can be helpful and you can facilitate, but it's hands off. And you can only really be hands off if you totally understand normal. So I have a new appreciation, and when it comes to resuscitation, it's really important to understand that it's hands off, except when it's not, and then you do the simplest, gentlest, most appropriate thing, which is to ventilate, and I will be getting into that. Now, NRP has 3 indications for positive pressure ventilation, and as I said earlier, they haven't really changed in the past, at least 3 books. Apneic, gasping, heart rate less than 100, right? Those are the same. I have added my own indications for positive pressure. NRPs, apneic, gasping, heart rate less than 100. Mine is not breathing or not breathing well. So if you can't remember apneic, gasping, heart rate less than 100, you can just use not breathing or not breathing well. If the baby's not breathing well, it's an indication for positive pressure ventilation. That's just what it is. Now, I'm going to add to that. I want to be clear, it's not stated this way, though I will explain how it is stated. But it is not really stated this way in NRP. But I would also say retractions, grunting, flaring, and rapid respirations, because these are all respiratory distress. This is all the baby not effectively getting enough oxygen into their lungs. They're working at getting more air into their lungs. Remember, if that's not the problem will still be there. So if the baby is septic, if the baby has meconium aspiration syndrome, if the baby has a congenital defect, if there's a pneumothorax, it doesn't matter. If that's not the problem, it's not going to resolve the problem. The problem is still going to be there. I'll give you a little example. There's a midwife that I taught for many years. She has a big birth center in Colorado, and she shared a class one of the times. She said, you know, and I've been teaching her and her group for many years, but she said, we had a baby the other day, and it was about, I'm going to say, it was about, 20 minutes postpartum, and maybe 15 minutes, they started noticing some retractions. And maybe they just weren't aware of it earlier, but she said, I just thought, let's do the 5 inflation breaths. So she did the 5 inflation breaths, and boom, that's it. The baby wasn't working anymore. They had a normal postpartum. It totally resolved the problem. The baby nursed. Everything was fine. She said, but we had a baby about 3 months ago and 4 months ago, and it was about 45 minutes postpartum, and the baby started having rapid respirations. And she said, always for rapid respirations, those 5 inflation breaths always work. So I did the 5 inflation breaths, and no go. The baby still had rapid respiration, so we transported the baby, and it turns out that the baby was GBS positive. It wasn't the problem. If it's not the problem is still going to be there. It's not going to resolve the problem if that's not the problem. It's just that it's the most likely problem. So if it's the most likely problem, you want to do the resolution for the most likely problem first. It's not going to create another problem, but it is the most likely problem that a newborn baby is going to have. And it doesn't matter what the issue is, you have to move to ventilating, because once the baby's born, that's the only way the baby's going to get oxygen. So even if they have meconium aspiration syndrome, you still have to ventilate until the baby can be put on a ventilator, which is ventilating the baby, or on a heart-lung bypass, but you have to ventilate till they can get there. It's the only option in a severely compromised baby is ventilating. Now, what they do say in NRP is if the baby has labored breathing, you should consider a trial of CPAP, which most out-of-hospitals don't have, or positive pressure ventilation, right? So there you go. You have labored breathing, try positive pressure ventilation, because it's the most likely problem. And if you can really understand how to make sure the breaths are going in, that is going to help you, because often, because we're not comfortable with ventilating, we're afraid to ventilate, we haven't ventilated, we don't have it down. So when we do it and the baby doesn't come around, we think that's not the problem, but really it's because you're not doing it effectively. But I'm going to walk you through that.